So welcome everyone, bright and early this morning. We want to try to have this be a conversational kind of setting. We're going to talk as colleagues, and you're our colleagues too. We want to leave some time for questions, but we have a lot of material too. So at the end, we'll have questions and comments from you all as well. We're going to be talking about major depression today, and we're going to focus on cognitive dysfunction, sexual dysfunction, and weight gain, the three things that nobody wants to have. I'm Anita Clayton. I'm the David C. Wilson Professor and Chair of Psychiatry at the University of Virginia. And Dr. Vladimir Maletic is a Clinical Professor of Psychiatry and Behavioral Sciences at the University of South Carolina School of Medicine.
These are our disclosures. As you can see, we have been very involved in development of more recent molecules used in psychiatry. Further disclosures pertaining to CME, our learning objectives. Okay, what may be some of these unmet needs in treatment of major depressive disorder? I think that most of the information that you see on this slide you will be aware of. For example, that depression, previously being defined as a mood disorder, definitely is manifest with emotional symptoms such as depressed mood. There's also loss of interest required for identification and definition of major depressive disorder, duration, and so forth. What is not as well known is amongst top 4 symptoms of major depressive disorder, in frequency, depressed mood is the only one that makes the top 4 list. The rest of the symptoms have to do with physical manifestations of major depressive disorder, including fatigue, sleep disturbance, changes in appetite. And unfortunately, often neglected, cognitive symptoms are major obstacle to appropriate functioning in major depressive patients. So difficulty making decisions, difficulty attending, especially if the material is not fascinating. Those are the kinds of challenges that interfere with our patients' functioning to a significant degree. So saying that there is a difficulty doesn't really do it full justice. If we treat major depressive disorder, somehow we have grown to assume that all the symptoms will respond within the same time frame and equally well. Unfortunately, there is nothing further from truth. You see the purple line? This is the response of core symptoms of major depressive disorder in terms of weeks of follow-up. And you see that within early weeks, core symptoms tend to respond well. Which ones do not respond very well? The terrible triad, cognitive problems, sleep problems, and lack of energy, not only have less robust response to pharmacological interventions, but also it tends to be delayed. So these are the ones that lag behind. And as an answer to the first question, unfortunately, the pessimists in the room were correct. So about 94% of depressed patients will have some degree of cognitive difficulties during acute stage. Even amongst responders, more than 2/3 will still have cognitive difficulties. And sadly enough, even if they meet criteria for remission, more than 40% will still be struggling cognitively. So these are staunch symptoms. They don't give up very easily. Something else that has quite a bit of bearing on our conversation is that cognition and response of cognitive symptoms to treatment changes with time. So what we are looking at here is something that's called Trail Making Test A. It's a very simple task. You know, in children's journals and magazines, when there are dots with numbers next to them and they're supposed to very quickly connect those, that's Trail Making Test A. So for individuals who are not depressed, to complete this task, it takes about 25 to 30 seconds, right? Depending on how much coffee I've had this morning. What happens if somebody's depressed? It takes them double that much time to complete the task. With successful treatment, these numbers resolve. So look first at the navy line. This is baseline, right? And then after you've successfully treated this condition, look at the red line. It is reduced to 30-something seconds. So they're approximating people who are not depressed. Look what happens with more episodes. Once they've had 5 or more episodes, it takes them, again, the task that should occupy 25 to 30 seconds, it takes them now about 90 seconds. So 3 times as much time to accomplish this task. And the sad part is even when they're in remission, that number comes only down to 80%. So cognitive scientists are now talking about cognitive scarring in depressed patients. As whatever the underlying pathophysiology is, it seems to consolidate with time, and it doesn't seem that these patients come back to their baseline. So something that ought to motivate us to be more aggressive and keep the episode count as much as we can. Now, when we're talking about cognitive difficulties, what exactly are we saying? Well, there are a couple of studies that have attempted to address this. This is just one of them. And here's what the finding is. Amongst individuals who suffer from major depressive disorder, mind you, these are treated patients. They still have similar degree of cognitive dysfunction when it comes to psychomotor functioning and attention, also learning, similar to people who have been kept awake for 24 hours. And this is similar to somebody who is legally intoxicated. So our treated depressed patients have the same degree of cognitive functioning as somebody who is legally intoxicated, as somebody who has been kept up 24 hours, right? So this is nothing to sneeze at. And frankly, other studies have found that it is similar degree of cognitive impairment in somebody who has had mild to moderate head injury and similar to somebody who is high on marijuana. So that is the world that our patients live in. Is this influential? If we look at the impact of cognitive dysfunction vis-a-vis overall functioning, it is not the leading cause. Severity of depression will be more representative in terms of functional limitations in depressed patients. But if we focus our gaze on how much do symptoms of depression impair work functioning, that is when we find out that cognitive impairment is number one, has stronger association with work impairment than global depressive symptomatology and intensity of depression overall. So again, this is the key component that needs to be addressed so that people will be able to work. And of course, you're aware that the greatest cost associated with major depressive disorder is in presenteeism. People having diminished functioning at workplace. Now, to quickly change topics, although this is not a complete change, as you will find out very quickly, there also seems to be an association between body weight and depression. So we are first looking at the graph on our left side, and here we see PHQ scores. To quickly orient you, 5 to 9 is still considered to be subclinical depression. 10 to 14 would be moderate, above 15 severe, above 20 very severe. So individuals who have severe depression are twice as likely to be obese as individuals who are not depressed. So there is an association that leads from depression towards obesity. How about the other way around? Now we're looking at BMI, and you can see that individuals who have BMI 35 and above, using 2 criteria, either diagnostic criteria or PHQ score above 10, have double the rate of depression as individuals who are lean, who are below 25 in their BMI. So there is a bidirectional relationship between those. Obviously, it suggests that this is something that we need to monitor and take into account when approaching our depressed patients. And Anita, can you tell us if there is any difference in terms of change in weight in acute setting versus long-term treatment with depressants? What should we watch out for?
So obviously, if you gain weight quickly after the initiation of therapy, patients are going to be able to identify that they believe that the medication is contributing to that. Sometimes it's just regaining the weight they lost with their depression if they have a melancholic type of depression. But a lot of times it is related to the antidepressant. And for those of you as old as me, you can see there on the left, it's tricyclic antidepressants and mirtazapine. So patients usually can identify that early on, or on the right, sorry. If you look to the left, bupropion, which we know is not likely to be associated with weight gain acutely. People recognize that if they lose weight. And then if you look at the SSRIs and a little bit greater risk with SNRIs, or some of them, what you can see is that early on, they're not gaining weight. But if you look down at the maintenance phase, after a certain period of time, we see a shift in which with SSRIs, we start to see weight gain. And you continue to have the weight gain with tricyclics and mirtazapine. So it's really the SSRIs where you see this shift from what you see acutely in terms of change in appetite and weight and what you see in maintenance. And that was a meta-analysis by Seretti, and he also did a meta-analysis related to sexual functioning. And these were studies in which a placebo was involved. So these were longitudinal studies, not cross-sectional. And they were in a variety of countries using different kinds of measures of sexual function. And it's important for us to think about sexual functioning as either having a phase affected like low desire or orgasmic dysfunction, or having pan dysfunction or global dysfunction across essentially all phases. And what you can see here is that the SSRIs as a class contribute to some form of sexual dysfunction, so it could just be one phase, in over 80% of the patients. If you look at the SNRIs, there's some mitigation there, probably from the noradrenergic effects. Still, you're talking about 40%. And then you can see placebo here is the fourth from the left. And there are 3 drugs available, not all available in the US, in which they probably have improvements in sexual function, or certainly no worse than placebo. And that's bupropion, nifazodone, and agomelatine. Keep in mind, too, that the relationship between depression and sexual dysfunction is also bidirectional. So if you have major depression, we know that many of those people may have sexual dysfunction, and that risk is increased 50 to 70%. It's even more shocking when you look the other way. If people have sexual dysfunction, their risk of developing major depression is 170 to 210% increased. So we really need to be thinking about the bidirectionality of these relationships with weight, with cognition, and with sexual dysfunction. One of the reasons we need to think about this is because patients always don't do what we recommend, right? And what they often do is just discontinue their medications and then eventually come in and tell us they did so, right? They also sometimes skip doses and in an attempt to try to reduce the side effect burden that they're experiencing. And then sometimes they might come in and tell us that they want to change their treatment. And then there are the people who have adverse effects that they relate to their medication, but they feel like the benefit of the antidepressant has been so great that they just put up with the adverse effects. If you look at this study, though, the reason people really discontinue their medications is because they don't think that they're working for them. So that's the most common reason. But they also stop because of sexual dysfunction, particularly loss of sex drive, couldn't have an orgasm, and weight gain. And then if they tell you that the ones that are the most difficult to tolerate because they're continuing to take their medications as recommended, the biggest one is weight gain. But you can see also different aspects of sexual dysfunction, erectile dysfunction, orgasmic dysfunction are in the mix too. So we either are making our patients miserable or we're causing them to not take their medications if we don't pay attention to these adverse effects.
So the big question is, given that these are very important symptoms, how can we assess those? A very simple way, this is something that you can easily download from internet. If you just Google PDQ, Perceived Deficit Questionnaire, you will get a PDF. You can download this. It is a fairly useful instrument. You're seeing just selection of questions that are present on PDQ, but it may have some shortcomings. This is subjective. And when it comes to cognition in major depressive disorder, we have to deal with so-called pseudospecificity. And what is that all about? The more depressed the patient is, the more they think they have cognitive difficulties. On the other hand, once we initiate treatment, if your antidepressant is effective and results in global improvement in depressive symptomatology, patients will start reporting that their thinking is better. What is the issue here? They feel that it is better, but if you do neuropsych testing, it is not reflected in improvement in neuropsych scores. So there is a bit of discrepancy between objective reality and subjective impressions. So again, this is one subjective scale. It may be a useful orientation, may help you map out some of the cognitive symptoms and maintain them as topic of conversation with your patients. But don't be 100% certain that changes in PDQ will reflect actual changes in cognition. Another instrument that is available is Mass General Cognitive and Physical Functioning Questionnaire. In addition to cognition, it does inquire about energy levels and some other physical symptoms of depression. So it is mixed. It has been validated. It is a useful instrument, and it is available. Unfortunately, digit symbol substitution test is patented. Now, I'm going to be a little bit sneaky and offer a way around it. But hold on for just a minute, right? So this is something that has been part of Wechsler Adult Intelligence Scale. It has been available for decades upon decades. It's a very simple test. You see series of digits from 1 to 9 at the top. Under each digit, there is a symbol. Now, there are below rows of numbers. One needs to write in a symbol as quickly as you can. Why as quickly as you can? Because you only have 90 seconds. This would be actually a good little thought experiment for us to try to do it this morning. But again, we recognize that coffee titers may not be sufficient still, so we'll just set it aside. Suffice it to say that in healthy individuals, we should score about 50. Right? In the patients who are depressed, that score is substantially lower. So what kind of cognitive dimensions are required to complete this task? Well, number one, you have to have working memory, because if you can keep these pairs in your mind, you'll be much quicker. You obviously need to have good psychomotor speed, because this is a time test. Attention. If your mind is wandering all over the place, you will not have a good outcome. And finally, executive function, because one needs to figure out a way to prioritize. So although it is often interpreted as test of psychomotor speed, there are other dimensions that are involved. I mentioned that there is a shortcut. THINC-it is an instrument that was developed by Roger McIntyre and his group at University of Toronto. It does include digit symbol substitution test. There's also trail making test A. There is a section that deals with definition. So it evaluates various aspects of cognition, including subjective. PDQ 5-item version is included in THINC-it tool. Here's the beauty of THINC-it tool. It is downloadable app that is free. So you can have it, your patients can download it, and you can monitor changes in their cognition with THINC-it tool, where it will be a multi-dimensional picture. You will have an idea subjectively what is going on, but you will also have reliable objective findings. It is structured to where it's very, very easy to use by patients. Now, Anita, I think you know quite a bit about this instrument, Change in Sexual Functioning Questionnaire. I'm being a little bit facetious because Dr. Clayton is the person who actually constructed and validated this instrument. So I dare say there's nobody on this planet who knows more about it. Why don't you tell us a little bit about this instrument?
Thanks, Vlad. It's a lot easier to initiate a conversation talking about sexual functioning if you can introduce the topic in a sort of non-threatening kind of way. Most of us have not had a lot of training in talking about sexual functioning, and we're a little bit worried about it, especially thinking that people might think we're being seductive, or they might tell us something we really don't want to hear in terms of something that's fringe or out there or whatever. We developed this scale because it has instructions at the very beginning that just says we're asking about your sexual activity, which could include sexual activity with a partner, masturbation, etc. And so we really don't have to know what exactly they're doing, only that when they do it, how do they function. And so this is a 14-item questionnaire. It's a self-report, and it's on a Likert scale. For men and women, there are 8 items in which they're the same, because in fact the physiology of sexual function is very similar between men and women. The differences being the physical manifestations of arousal, erection, or vaginal lubrication. And so those questions are asked about separately in those two, the pink for the women and the blue for the men there. And they're similar but not exactly the same. Higher scores are associated with better sexual function, and lower scores are associated with dysfunction. There are threshold scores for men and women that have been established statistically, and there are threshold scores for the subscale scores in it too. The analysis can either be dichotomous, that is, patients can either have or not have meet criteria for sexual dysfunction, or it can be continuous, where we can look at the change in their scores over time, and that can be very valuable. We use this clinically when people come into the clinic. We give the PHQ-9, we give the GAD-7, and before we initiate treatment with an antidepressant or other medications, we usually administer this scale.
That's a good point. It's good to know what the baseline is.
Because we know that depression and psychosis, for example, contribute to sexual dysfunction. There's another scale too, the Arizona Sexual Experiences Scale, or ASEX, is a 5-item scale, also has separate questions, number 3 for the arousal phase questions. But it's in the opposite direction. Higher scores are associated with more sexual dysfunction. And this is really just a dichotomous analysis. Do or they don't meet criteria for sexual dysfunction.
So it may not be as fine-grained as the instrument that you have developed.
And as easy to understand in the context of studies that are done. Those are the 2 scales that actually have been recommended by the FDA for looking at sexual functioning with medications, psychiatric medications.
So we'll talk a little bit about pathophysiology in context of major depressive disorder. There is a neurobiological component that is transdiagnostic. So in major depressive disorder, in bipolar disorder, in schizophrenia, in all those conditions, we can say that there is compromise of cognitive control. What it means is that prefrontal cortical areas have insufficient impact on limbic system, and therefore do not appropriately regulate emotions. When we speak about regulation of emotions in cortex, it may be useful to think about 2 types of circuitries involved in emotional regulation. One is automatic or implicit. The other one is explicit or volitional. To give you an idea, this is how you might evaluate automatic regulation of emotion. Patient is in a scanner, and they are looking at pictures of houses. They have a little response instrument in their hand, and here's what they're supposed to respond to. If the houses are the same, you press the left button. If they're different, you press the right button. That is it, right? But it's a very sneaky paradigm, because between the pictures of the houses, usually for about 40 milliseconds, they will flash a photo of strong emotional expression. People who are really angry and people who are really sad. 40 milliseconds is not enough for this picture to register in occipital cortex. So these individuals have absolutely no idea that they're seeing these facial expressions. On the exit interview, you will ask them, well, what have you been looking at? And they will say, well, mostly pictures of the houses. Anything else you saw? I thought maybe a light flickered. That's it. Now, here's the intriguing part. If you're not depressed and you're looking at really frightened faces or angry faces or sad faces, your automatic regulation of limbic system, of amygdala signal will be in place, and it will not leave an emotional trail behind it. If the person has depression, these faces with strong negative impressions will leave an emotional aftertaste, if you will. You will have robust increase in threat and danger circuitry in the brain. So this is very hard to deal with because it is outside conscious. Depressed patients don't know about it. The other part has much more to do with volitional regulation of emotion. Let me give you an example of volitional regulation of emotion. Let us say this is a weekend, and Orlando is probably not the best place for this kind of metaphor. North Carolina is better suited. Let's say you are in the western part of North Carolina, and you're planning on spending a weekend in the mountains to relax because it's been an awful day in the office, right? And you're driving on a Friday afternoon. It's getting dark, but beyond dark, it's getting really cloudy, and halfway up the mountain, you're driving tight turns. All of a sudden, it opens up, and it's sleet, and it's snow, and you're having a hard time keeping the vehicle on the road, right? And all of a sudden, out of the corner of your eye, you see a spider slowly lowering itself right towards your hand on a steering wheel. So here are your options. To do what you reflexively would like, which is to scream and let go of the steering wheel, but you're going to drive right off the road and kill yourself, right? Or to say, okay, I need to stay calm. You know, whatever spider does to me, it's not going to be as bad as going down the mountain, right? And that is volitional regulation of emotion. Both are compromised in individuals who have major depressive disorder, but automatic regulation of emotion is compromised more. This is one of the big distinctions between MDD and bipolar disorder. Be it as it may, when it comes to prefrontal cortical activity, which is working memory and executive function and top-down regulation of emotion, compromised in patients who suffer from major depressive disorder. Now, there has been a loose correlation created between symptom domains, manifestations of major depressive disorder, and some of the major monoamine neurotransmitters. So we see that energy and interest is predominantly assigned to norepinephrine. Motivation is norepinephrine and dopamine. Impulsivity, mood, anxiety have to do with both norepinephrine and serotonin. How about sexual functioning? Which neurotransmitters, this is something you know a whole lot about, which neurotransmitters are involved in that one?
So really, all of them.
All of them. The answer, so which neurotransmitters are involved in regulating sexual dysfunction, you have just learned the answer is yes. In other words, yes, they all play a significant role. So when it comes to depression, serotonin, norepinephrine, are they really off? This is a study with rather simple methodology. So this is what they used. We know that norepinephrine regulates release of growth hormone. So if you use an alpha-2 agonist such as clonidine, and then you measure growth hormone levels, you can make some kind of assessment of norepinephrine function. If growth hormone levels over a period of time are different in depressed individuals than the ones who are healthy, then you know that there is a difference in norepinephrine function. You can also assess serotonin function by using a pharmacologic provocation of serotonin system, and that is dexfenfluramine. Remember the fen-phen diet? That's the dexfenfluramine is part of it. That is the most potent serotonin releaser. Serotonin, of course, impacts on prolactin levels. And you will hear actually quite a bit more about it in just a few minutes. So if you measure prolactin levels then, and you see a difference between healthy individuals and depressed individuals, you know that there's something off with their serotonin function. If we use this method of assessment, what are we finding out? Only about 30% of depressed individuals have impairment in serotonin signaling, either in isolation or combined with norepinephrine. 30%. When it comes to norepinephrine, either isolation or in combination with serotonin, that's about 50%. Which leaves us with about 40% of depressed patients who do not have impaired serotonin and norepinephrine transmission measured by this method. So 40% of our folks may actually have no problem with serotonin and norepinephrine, which invites us to start thinking about something that I think has become rather obvious to you by now. There is no such thing as MDD when it comes to uniform, monolithic neurobiology. So it is not neurobiologically a single condition. The way you found out about it, if it was, then there would be one best antidepressant for everybody you're treating, and you know very well that that's not the case, right? A little bit of a surprise, patients who will have the greatest problem with the anxiety are the ones who have norepinephrine, not serotonin, but norepinephrine abnormality, and they tend to be male. If one has both norepinephrine and serotonin abnormality, one will have more depressive episodes, moderate anxiety, and at least in this small study, those were more females. So we see that monoamines not only talk to each other, but ultimately they regulate GABA and glutamate signaling. So if we're thinking about monoamines, do not fence yourself in saying we're just manipulating serotonin and norepinephrine and dopamine. It is not possible to regulate monoamines without regulating ultimately GABA and glutamate. So one thing is to have pharmacologic selectivity. While you can achieve that to some degree, there is no such thing as physiological selectivity. They're interconnected. But Anita, they're not interconnected in exactly the same way. Some of these have more influence. Wouldn't you say so?
Yes. And in reality, it's serotonin that's the big bully here. Serotonin has a greater ability to regulate norepinephrine and dopamine than they have to regulate and moderate serotonin function. And we need to keep that in mind. So that's why serotonin in some ways has become prominent, is a great target sometimes for treatment. But we need to keep in mind how it can also have negative effects.
And we can also speak about our agents in terms of modes of action. So if we are considering SSRIs, they only have selective serotonin reuptake inhibitor. How are they different from serotoninergic tricyclics? Selectivity is based on affinity for a certain kind of receptor. If it is selective, it has one order of magnitude greater affinity for that receptor than anything else. So if an SSRI has affinity for other receptors, it has to be at least 10 times less, right? That is what defines them as category. So one mode blocks serotonin pump. Then we have medicines that have two modes, such as vilazodone, right? One mode is it blocks serotonin pump. The other mode is it blocks or antagonizes one of the receptors, in this case, serotonin 1A receptor. Then we have SNRIs. They have two receptors, serotonin transporter and norepinephrine transporter, but this is only one mode, uptake inhibition. Two different targets, but only one mode. And then we have agents that are, for the time being, thought of as multimodal. And you see that one mode is blocking the transporter. The other mode is influencing a number of different receptors. Now, you might notice that there is some differentiation there in a sense that it influences two types of receptors, so-called ionotropic and G-protein coupled receptors. What is the relevance? If you modulate G-protein coupled receptors, you will have much delayed response. If you modulate ionotropic receptor, the only one here is serotonin 3. You have response in fractions of a second. It's instantaneous. So it is kind of 2.5 modes because you have different types of receptors being modulated. Now, what is the point? The point is not to make things confusing. These are not randomly designed antidepressants. They're designed with a strategy in mind. And the strategy is to avoid delay in activity, and therefore homeostatic loops that are managed with serotonin 1A, B, and D receptors are disconnected, so you can have a theoretical earlier rise in serotonin. Number two, to limit collateral damage. When serotonin is increased everywhere in the brain, and that is what we do when we block serotonin pump, in the prefrontal cortex, serotonin 3 receptors have only one location, and that is on GABA interneurons. So you boost serotonin, it attaches itself to serotonin 3 receptor on GABA interneurons. What does GABA do? Inhibit. So collateral damage is that you have inhibition of a number of different neurotransmitters in the prefrontal cortex, such as glutamate, acetylcholine, norepinephrine, dopamine. All of those slide down. And some researchers believe that this may be basis for something that we call SSRI-induced psychasthenia. So again, this is an intelligent design trying to minimize some of the collateral damage and enhance the onset of action of antidepressants. Now, something that has been our age-old ambition in treating major depressive disorder is to construct an arc where we will have relationship between genetics, between underlying neurobiology, and ultimately manifestation of major depressive disorder. Also, it would be useful to have some kind of treatment implications. And I'm delighted to share with you that pieces of that mosaic are coming together, at least for some subtypes of depression. So this is how it began. It started with genome-wide association studies. You have a sub-analysis on this slide. To give you an idea, this is pooling of 5 genome-wide association studies, total number over 100,000 depressed patients. Large number. They looked at the genes that are associated with depression and concluded there are roughly between 80 and 90 genes that have some association with major depressive disorder, all have small individual effects. Some of our depressed patients, this is very easy to ascertain, have increase in appetite and weight gain. So if they have increase in appetite and weight gain, might they have some genetic overlap with people who manifest obesity? So then you study a large number of patients who have obesity, and here's what you find out. There is an overlap. So patients who are depressed have up to 19 genes that are otherwise associated with obesity. And then you look at this overlap and what kind of biological signals will you have in that subgroup of patients who have increased appetite and increased weight. And here's what they found out. Not only are they more likely to have a BMI above 30, but they're more likely to have peripheral inflammatory signals as measured by C-reactive protein. And the other thing that we're finding out is that communication between their adipose tissue and the brain is disrupted. Chemical signal from adipose tissue, which is supposed to deliver a message to hypothalamus that we have abundance of calories on board and that our appetite can be diminished, is leptin. These individuals are drowning in leptin. However, their leptin receptors in the brain are insensitive. So you are sending an email to an account that has been closed. The message is just not arriving. And we're finding out that the more genes associated with obesity these individuals who have depression have, the more likely they are to manifest that phenotype of increased appetite and weight gain. So now things are beginning to line up. We have genetics, we have biology, we have clinical manifestation. So is this a known subtype of patient to you? Well, number one, it's needless to say that if they have increases in leptin and leptin insensitivity, they will also have greater weight and greater waist circumference. That is quite logical, right? What else is it related to? Just look at these tertiles of leptin and BMI. High leptin, high BMI translates into 3.5 times likelihood that the patient you're looking at is the patient with atypical depression. So a patient that tends to be sleepy a lot, that has low energy, less ability to enjoy life, an increase in appetite, not loss, and because these vegetative signs are going in the opposite direction, it is labeled as atypical depression. But we know, Anita, typical depression in women is not really atypical, is it?
Right.
No, yeah, right?
That's the typical depression for women.
So I hope you're tracking. Atypical depression is typical depression in women. You have heard it here this morning, right? So how about neuroimaging? Are there neuroimaging correlates? Well, few things. Indeed, individuals who have this atypical depression with increase in appetite and weight gain have more robust inflammatory cytokine signaling in the periphery. Again, the signal is not delivered to hypothalamus. But there is something else that is quite interesting. When they are in a scanner and you show them pictures of juicy burgers, of creamy cake, it will set their reward circuitry on fire. Anterior mid-insula, ventral striatum are firing at a rapid rate. There is excitement. This is like catnip. Show them appetizing foods, they can't resist it, right? That is something that is a feature of atypical depression. It is quite different in individuals who suffer from melancholy depression. And this one is mostly male, isn't it? You show them appetizing foods. I mean, you could be showing them celery sticks. Just nothing is happening in reward circuitry in the brain. There's absolutely no interest in appetizing foods. There's typically loss of appetite, and the weight is either normal or a little bit lower. And this tends to correlate with increase in cortisol. You still may remember cortisol, dexamethasone suppression test to evaluate HPA regulation of cortisol. These are the folks who have impaired dexamethasone suppression test. Their morning cortisol is high, their evening cortisol is high, they have flattening of cortisol curve, and the more it is present, the less reward circuitry activity you will see. So we are now seeing not only phenomenological but biological distinctions between these patient groupings. And we also recognize that increase in BMI may be associated with decline in cognitive function, possibly mediated by peripheral inflammation, which we all also know is associated with impairment in cognitive functioning. You don't have to go very far. Think about how your cognition is when you have not slept a whole night, and think about how your cognition is when you're coming down with flu. Does your mind feel a little bit foggy? That's inflammatory cytokines, right? And the relevance for treatment is there seems to be a relationship. 3 studies now, initial study by Kloiber and colleagues from Germany. Now there are 2 studies that have come from Canada, all showing the same phenomenon. I will invite you first to look at the turquoise curve. These are folks who have BMI below 25. In this 5-week study with variety of different antidepressants, average person with BMI below 25 was a responder. Now look at the purple curve. Those are individuals with BMI above 30. Average person with BMI above 30 was a non-responder. So BMI may actually be an indicator of likelihood of response to a variety of different antidepressants. This has been a little bit more refined. Now we are in 2018. This is this year's publication. So will patients' weight in any way prognosticate response to a certain type of antidepressant? And here's what we're finding out. If somebody has BMI below 25, they are likely to have pretty good response to SSRIs. On the other hand, this may catch you by surprise. If somebody is lean and you add bupropion to an SSRI, you're subtracting from their remission rate. So combination subtracts from remission rate. Dual-acting agent combination is doing quite well in lean patients. Now you go on to folks who have BMI over 35. So they're clearly in obese category. What you're finding out that with SSRI in these patients, you will almost have placebo-like response. But on the other hand, here, if you add bupropion, you're increasing remission rate by about 20 points. So this is something that is clearly translatable into clinical practice. It is awaiting confirmation. The numbers are not as impressive as we would like them to see, but it remarkably coincides with inflammatory indicators. If you look at CRP below 1 and above 1, you will get exactly the same kind of distribution. So can you now help us understand, Anita, what are the factors? Sexual response is very complex. Most guys don't figure it out until about 50 or 60, where unfortunately maybe a little bit less relevant. So please tell us about this complexity. What should we know about regulation of sexual response?
So luckily, we don't really have to understand this to do it, right? But
we'd be in trouble otherwise.
Yeah, we would be in trouble. But in truth, these factors are probably playing a role in literally everybody, whether they are satisfied with their sexual functioning or not. So the first thing is biology, and we're talking about mostly that today. But we're looking at things like neuroendocrine function, medical conditions, medications that people are taking, and those are going to sort of form the basis of the pyramid of effects, and we've got to pay attention to those. Then there are intrapsychic phenomena, so things like performance anxiety and body image. And if you start to think about obesity, particularly for women, that impacts on body image. Then there's the interpersonal relationship. So if you're having partnered sexual activity, you're going to have to think about that. The nature of your relationship, of past relationships, trauma, history, intervals of abstinence. Often we don't think about that. But if you don't use it, you lose it. And it's hard to get back into a pattern of reestablishing that sexual relationship when you've been away from it for a while. Depression certainly interferes with that when people are socially isolating. And then finally, there's the big umbrella of sociocultural phenomena, and that includes religious phenomena. And these tend to be restrictive in terms of activities that are sexual. So your family upbringing may have something to do with what you believe about that, your religious background, and other cultural restrictions that tend to be more so for women, but still apply to both. And we need to keep that in mind. So all of these things together are probably playing a role. Some of them will be more important in a particular individual over others. I do want to talk a little bit about the biology. The majority of people have sort of a linear response in terms of their sexual desire and response. And they're overlapping. If you have desire, you're more easily aroused. You must be aroused to have an orgasm, and having an orgasm tends to enhance your desire for future sexual activity. These are modulated in the brain by sex steroids or hormones and also neurotransmitters. Testosterone tends to be a big driver for men because levels are higher in men. But remember that women have testosterone, they produce it, and then they convert it to estrogen. And estrogen actually influences sexual desire in women to a much greater degree. Progesterone, which fluctuates across the menstrual cycle, is likely related to being receptive to partner approach. So if your partner approaches you and your progesterone function is adequate, that may have something to do with your saying yes. Also, psychosocial factors are going to have something to do with you saying yes at that time, too.
Nita, I'm a little bit confused. I see that with serotonin, there's both plus and minus sign. Can you help us understand that a little bit better?
So serotonin is going to enhance estrogen regulation, but it can diminish testosterone levels. And what you really want is free testosterone. You could have high levels of total testosterone, but if you have sex hormone binding globulin, you're binding it all up and you don't have it available to drive this system.
Okay.
And serotonin has other effects too, but so do other hormones. So for example, prolactin, even tiny increases in prolactin are going to have an impact especially on central or cognitive arousal and then spread to the other phases. And oxytocin levels fluctuate across the menstrual cycle and are drivers for women to participate in sexual activity around the time they're ovulating, but they also rise in both genders at the time of orgasm and have to do with feeling attached and close to the person with whom you just had this wonderful experience. Melanocortins also play a role, and they're generally stimulating both dopaminergic and noradrenergic activity. And that's where we get into all these transmitters impacting on sexual function. So we've got dopamine, which has to do with desire and behavioral motivation, doing it, getting involved in it, not just passively thinking about it, but also in staying in the moment, that focus that is pretty critical to maintaining arousal.
Not a good time to get distracted.
It's not. And then norepinephrine is related to arousal in general. So, of course, it's going to be related to sexual arousal, including those cognitive processes of building excitement. I want to be here. This is a good thing. I want to see this through. Unfortunately, serotonin, as I told you, can modulate norepinephrine and dopamine better than the other way around. And so when we enhance serotonergic function, we're probably going to be diminishing dopaminergic and noradrenergic function, particularly as it relates to sex. We also, as I mentioned, see effects on the sex steroids like estrogen and testosterone. So it's a pretty complex environment that's acting on our brains.
As you said, we're lucky we don't have to understand it.
We don't have to think about it to make it happen. In the periphery, men and women are still pretty similar. We need to have sex steroids to maintain the structure and function of the genitalia. That's important. And we also need to have some other neurotransmitters that are impacting on our sexual function. What we're really looking for is vasocongestion. That drives an erection, and it also drives vaginal lubrication. And norepinephrine is pretty strong in effects on vasocongestion. Interestingly, though, norepinephrine also turns on an interneuron, the 5-HT2A interneuron, which shuts down the system. So remember I said it's inhibitory. It's going to shut down our genital arousal, too. And so this is a good thing. You wouldn't want to be aroused all the time. There actually is a condition called that, persistent genital arousal syndrome, and people even get suicidal over this because they're, even if they have an orgasm, they're very rapidly aroused. So just sitting still is going to make them uncomfortable. So we want it to shut down. It's just that when we've got more serotonergic function, we're shutting it down when we don't want that to happen. And nitric oxide is important in vasocongestion. That's what's in PDE5 inhibitors that we use for erectile dysfunction. And serotonin, unfortunately, has a negative effect on that system too. And in part, it's because it lowers testosterone levels, and you have to have adequate testosterone levels for nitric oxide to work in both men and women. And finally, serotonin also influences sensation, so it can diminish genital sensation, or it can cause hyperalgesia, so increased painful sensations. Not particularly desirable in sexual activity. And there's a few other neurotransmitters in the genitalia, cholinergic fibers, prostaglandin E, and even vasoactive intestinal peptide. What do? They probably have to do more with reproductive function, but we could still cause problems there. So what about the antidepressants? Most of you probably think about SSRIs as impacting on sexual functioning. Venlafaxine also does, because it doesn't really get a lot of noradrenergic activity until you get to higher doses. And then tricyclic antidepressants are big offenders, actually. It's just that we weren't studying sexual function when these drugs were branded and new. And people have a lot of day-to-day complaints about constipation and
blurry vision,
and we worry about their heart status with tricyclics. And then oral MAOIs, they're not used that frequently. Effective treatments, but not always used that frequently, and can cause sexual dysfunction as well. The drugs that have fewer sexual side effects and have been studied looking at this specifically are bupropion, mirtazapine, nifazodone, the salicyline or MAOI transdermal system, reboxetine, which is a norepinephrine reuptake inhibitor, duloxetine, an SNRI, desvenlafaxine, the same. Vilazodone, we heard, has two modes of action, vortioxetine, multimodal action, and agomelatine acting through the melanocortin system. So different mechanisms of action, not really driven directly by enhancing serotonergic function. In about 2013, the FDA had a scientific forum in which they brought together a lot of experts on sexual functioning to try to develop plans for designing studies that might lead to labeling for antidepressants having less sexual dysfunction. And they did a couple of things. They endorsed the ASEX and the CSFQ as instruments that would be appropriate to use in these studies. Those are the two that I mentioned earlier. They also talked about what study populations could be used. So they wanted to look at patients who have major depression being treated acutely, and they have data for a lot of the medications related to registration trials. The problem is that those are not robustly positive with regard to sexual functioning or differentiating, and it's in part because really the focus is on treatment of the depression, efficacy, safety, as opposed to tolerability. Also, they wanted to look at major depression in a maintenance setting, because those are really the people that we're concerned about. When people are depressed, they're like, get me better, and then they start to worry about their sexual functioning. People who have gotten better with regard to a lot of their depressive symptoms, but are experiencing sexual dysfunction, weight gain, cognitive dysfunction, these are things that are going to interfere with not only their quality of life, but their function in life. And that was of interest to the FDA. And then they also looked at a study that we had done before with normal, healthy volunteers who did not have major depression, because that takes the depression as a confounding factor out of the mix. So you don't have depression causing sexual dysfunction, you're just able to look directly at the medications and that effect. And then they also required that in any of the studies that there be a medication used as a comparator that is known to cause sexual dysfunction to ensure assay sensitivity, that is, that the study is legit. If you show that your medication is not causing sexual dysfunction and it doesn't really differ from placebo, if you didn't have a comparator that did look worse than placebo, then in fact you might think that this is an accident, or people just weren't reporting, or some other factors. And they also recommended 2 doses, because we know that for most of the antidepressants, higher doses are associated with more sexual dysfunction than lower doses. So there have been a couple of medications that have been looked at using these. I actually presented a poster, and it's still up, but I was talking about it with people yesterday, and that's one of the latter studies with vortioxetine. There are the registration trials, though, for vilazodone and vortioxetine used the CSFQ and the ASEX in them, and there are data suggesting better sexual functioning, but not as definitive as you might like. We published a while back on maintenance major depression, so patients who had a good response to their antidepressant therapy, which was sertraline, citalopram, or paroxetine, but they had treatment-emergent sexual dysfunction with those medications. They came in, they were randomized to receive either vortioxetine or escitalopram, 20 milligrams of each, and what was found with the CSFQ was significant superiority with vortioxetine over escitalopram, while both of those medications maintained the antidepressant efficacy.
That may have resulted, I believe, in label change recently.
Yes, so earlier this week, the FDA included that study and the next one that I'm going to talk about in healthy volunteers in the labeling for vortioxetine. So this is the first time that they've made these changes based on the study designs that they have recommended. And the data from these two studies are in there and suggest that vortioxetine 10 milligrams doesn't differ from placebo, and vortioxetine 20 milligrams doesn't really differ from placebo, but didn't differ from paroxetine until we accounted for non-adherence. So I don't know how many of you know that in depression trials, there are a lot of patients who really don't have depression. They're like fake patients. And there are a lot of people who don't actually take the medication that they're assigned to randomly. This is a big problem. This is why half the depression trials are failing to demonstrate a significant difference, even though we know antidepressants do work.
In U.S., I believe that number is about 14%. 14% of the patients assigned to the medicine actually don't take it in U.S. trials. U.S., by the way, is the most difficult country in the world to show differentiation from placebo in the antidepressant trials.
We also have a problem, though, with normal healthy volunteers. They come in, and in this study, these two studies, they knew that they were going to get an antidepressant that was known to cause sexual dysfunction, paroxetine, or they might get randomized to an antidepressant that might not cause sexual dysfunction, or they might get placebo. Just like people who come into major depression trials assume, they have it in their own mind that they're going to get active treatment and not going to get placebo, people who come in healthy volunteers want to get placebo. And so sometimes they don't adhere to the treatment. And in the case of both the vilazodone study and the vortioxetine study, there were significant numbers, but it only takes a few patients who never took the active treatment at all. And this was found through PK studies over the course of the study. But there were also people who came in, they were going to do what they were supposed to. They took the study drug, and then when they got sexual dysfunction, especially with paroxetine, they stopped taking it, but they didn't tell us. And then they reported, oh, I don't have sexual dysfunction anymore. Yeah, because you're not taking the drug that causes sexual dysfunction anymore. And that can foul up the data. So there were plans to look at non-adherence. And that really does make a difference when you're able to look at that. And so the finding with vilazodone wasn't significant until non-adherence was taken into account. With vortioxetine, it was significant with the 10 milligrams of vortioxetine versus paroxetine, very similar to placebo. And when non-adherence was taken into account, even 20 milligrams of vortioxetine separated statistically from paroxetine. So the takeaway from this is if your patients have sexual dysfunction on 20 milligrams of vortioxetine, because you've switched them to that, you might then lower the dose to 15 or 10 and be able to maintain antidepressant efficacy, but reduce their sexual dysfunction. Antipsychotics can also contribute to sexual dysfunction, and we're adding antipsychotics to antidepressants as augmenting strategies. And so some of them may be contributing to sexual dysfunction too. It's interesting, though, if you look at the D2 antagonist partial agonist effects and also the 5-HT2 antagonism that I mentioned, that's that interneuron that shuts things down, then you might see better sexual functioning or at least something neutral. So aripiprazole, quetiapine, brexpiprazole, ziprasidone, olanzapine, and lurasidone have been looked at with regard to sexual functioning with these related to the mechanism. And then 5-HT1A agonists, that's going to have essentially a reduction effect on serotonergic inhibition. Things like aripiprazole, brexpiprazole, cariprazine, and lurasidone all have those effects. And of the four of those, cariprazine hasn't been looked at with regard to sexual function, but it does have that mechanism. Other problems include postsynaptic dopamine blockade, elevated prolactin, and as I said before, it's only a little bit. You don't have to have galactorrhea to have sexual dysfunction. And a lot of women on antipsychotics have reproductive dysfunction, right? Their menstrual cycles get disrupted. They might get galactorrhea. And if your reproductive function is disrupted, your sexual function is probably disrupted
and
too.
Based on what you have just shared, Anita, it seems that we should be particularly concerned about combination of high-potency SSRIs and D2 antagonists because they may have synergistic impact on increasing prolactin.
Exactly. So keep that in mind. Other things like priapism, you don't see that frequently. I haven't even seen it that frequently, which is an alpha-1 receptor antagonism. The only times I've ever seen that was in combination of two drugs that did that. But when you see it, obviously that's a medical emergency. And persistent psychosis, just like persistent depression, is going to interfere with sexual functioning. And there was a study that tried to look at decreasing levels of sexual dysfunction with various antipsychotics, and you can see them listed here. I've plugged in a couple others where there were data that came after this, so clozapine and lurasidone both. I put them in where it looked like percentage-wise they work, so we should be leaning toward quetiapine, lurasidone, aripiprazole, and other drugs like them. I don't know if you can see this very well, but this is basically an algorithm about managing treatment-emergent sexual dysfunction. And I think it's pretty important for us to think about it up front. Like I said, we give a PHQ-9 and a GAD-7 and a changes in sexual function questionnaire to people before we initiate antidepressant therapy and antipsychotic therapy, in fact. If they've already got sexual dysfunction from their depression, they're probably at greater risk for having sexual dysfunction with their antidepressant, too. So it's not going to get better, and it could get worse. If they're worried about that, then we should be thinking from the beginning about giving them a medication that's not going to contribute to problems they don't want to have. I mean, what my patients basically say, I don't want to have sexual dysfunction, and I don't want to gain weight, right? I'm sure you'll say the same thing. Those are factors we talk about in the context of prescribing. Sometimes we give people something that may do that because they've been tried on everything else, or we say, well, we'll monitor you, and we weigh people at every visit then in order to keep track of that. I can tell you in clinical trials, I have people come in, we don't know, we're blinded to what they're getting, and they go, I'm gaining weight with this drug, this is terrible. And we weigh them, and their weight is exactly the same. So it's very similar to the cognitive reporting. Even weight, people think that they're gaining weight. And sexual dysfunction is a little bit different because people are just reluctant to bring it up. Once you bring it up, though, they tell us very easily and quickly what's going on, and people can fill out the CSFQ or the ASEX in just minutes. So you might want to choose a medication that is in line with the patient's preference. If you want them to continue to take the medication and you don't have any other data about their potential response. Sometimes we prescribe something that a family member has had a good response to, and people are saying, yeah, I'm okay with a risk of sexual dysfunction. But if they get the sexual dysfunction, then we maybe have to talk with them about what to do. We can watch and wait, and about 5 to 10% of people will get tolerance to sexual side effects with SSRIs, for example. But that's a long time for people to wait, and it's a pretty small group that gets that benefit. We can reduce the dose, but very often we're going to see reemergence of depressive symptoms or psychotic symptoms if we're using an antipsychotic, because we didn't just run them up to some high dose that they didn't need. We adjusted the dose up as they appeared to need it. And if we cut it back, they're not likely to do well. We definitely did that with tricyclics, right? You'd get people up to a therapeutic dose, they'd respond, and their side effects were so bad that you'd reduce the dose and everybody would relapse.
Many clinicians will bring up drug holidays. Just curious about your thoughts about drug holidays.
Yeah. So there was one study about drug holidays. It really was beneficial with the few short-acting SSRIs that they used. It didn't benefit patients who were on fluoxetine because their drug levels didn't change over the holiday on the weekend. Because most of us, on average, have sex about once a week. So people can time that and plan that for Saturday night or something like that. And so they wouldn't necessarily take their medication on Friday morning or Saturday morning, and then they might have sex. The problem is that for even for the short-acting SSRIs, you actually get discontinuation symptoms during that time, and that's not very conducive to good sex either. So I don't usually recommend it. The other problem is that if you do that and then it's effective for people, then what if they want to have sex on Tuesday? Then they don't take it Sunday, Monday, Tuesday, and then soon they're discontinuing their medication. And if you're going to discontinue somebody's meds because of sexual dysfunction, let's plan it and figure it out. And then there are a few non-pharmacologic options, but in general, they're not available to most of our patients, like specific kinds of therapy. If the real solutions are either to add an antidote, and we usually do that if somebody has a very effective antidepressant response in the current medication, and really their only problem is some sexual dysfunction, or we switch them to an antidepressant less likely to cause sexual dysfunction. And what I tell the residents is, let's just get it right from the beginning and help our patients in that way. I'm not going to talk long about this, but there are some new drugs that are in development that have completely different mechanisms of action, and most of them are potentially less likely to cause sexual dysfunction. So that's going to be a bonus. So if you look at GABA-A receptors, if you look at neurosteroid modulators, glutamate antagonists, K and mu opioid antagonists, these things are likely to work in the reward circuitry in reducing the excitatory or reducing inhibitory effects and enhancing excitatory effects, and that's a good thing.
How about cognition? Are there differences? Thank you very much for sharing such good information about the differences in terms of sexual adverse reactions. How about cognition? Are there agents that are more sparing of cognition than other antidepressants? This is a study that was conducted in a neuropsych clinic associated with UNC in Chapel Hill. Tom Galtieri was the author. He used an instrument that is a comprehensive neurocognitive battery. It does include elements such as attention, processing speed, executive function, memory, and so forth. And in this particular study, after patients spent 4 weeks on a stable dose of an antidepressant, they evaluated cognition. The finding was that bupropion was indistinguishable from healthy controls. So depressed patients treated with bupropion functioned at exactly the same cognitive level as healthy controls. On the other hand, substantial reduction in cognitive functioning in individuals who were treated with SSRIs and even venlafaxine. They were statistically not only different from healthy controls, but also from individuals who had been treated with bupropion. And then a meta-analysis conducted by Bernie Bond and his colleagues in Melbourne. I believe he's now in Sydney. And these are all the studies where there was a blinded comparison between an active agent and placebo. Digit symbol substitution test was the measure that was utilized in all these studies, and here is the finding. There was only one agent that demonstrated improvement in cognitive functioning, and that is vortioxetine. With the rest of the agents, you see some bars pointing in the positive direction, some in the negative direction. There was no statistical separation between them. But we're seeing that SNRIs, predominantly driven by duloxetine data, are slightly in the positive category. SSRIs, aside from sertraline, are all in the negative category. Monoamine oxidase inhibitors and nortriptyline are definitely in the negative territory. The only tricyclic that appeared to be relatively neutral was dizipramine. And now comes the question, are these agents working because they're improving depression, or is there specific impact on cognition that is direct? And this can be dissected using so-called pathway analysis. It looks at the correlation between improvement in depression scores and cognition. And the finding is that with vortioxetine, over 80% of the impact on cognition is direct, while with duloxetine, only about 25% of the impact on cognition is direct. The rest of it is indirect via improving mood. So that is something that we also need to keep in mind. Here is a table that provides level of evidence, and we see that when it comes to learning, attention, executive function, and processing speed, vortioxetine is the only agent that has replicated studies, so level 1. Level 2 is one controlled study. We see it with lisdexamfetamine and many agents that have level 3, meaning open label data only.
So I just want to talk quickly about thinking about excitation versus inhibition, because I think that that's pretty critical in these areas. If you're in the right place at the right time, you can do the things that you want to do, like have sex. I want you to keep in mind, though, that there are factors that have negative effects that we haven't mentioned yet. So serotonin we've already talked about, but hormonal modulators like opioids cause problems in a multitude of ways, the most common being reducing testosterone levels. And prolactin we've mentioned also, and neuromodulators like endocannabinoids also have significant negative effects on sexual functioning.
Oh, that's good to know.
There's complex reward circuitry. The key is mostly happening in the nucleus accumbens. You can see that where you've got dopaminergic projections, and then you've got excitatory glutaminergic projections and inhibitory GABAergic projections. So they're all interacting there, but through other systems as well. You can see mesolimbic, mesocortical, etc. And in looking at imaging, this is studies of men trying to assess paroxetine's effect versus bupropion's effect versus placebo. When in a scanner looking at erotic videos, because that's how you test all these things, and basically it mirrors the clinical response that we see, which is paroxetine was significantly worse than placebo. Bupropion was better, even in some cases, than placebo, and bupropion was markedly better than paroxetine. We have a case?
So we have a case. Why don't you introduce our patient, please?
Mrs. Robinson is a 47-year-old married woman. Her PCP referred her for treatment of depression to you, and her patient self-reports a history of several failed past treatment attempts with antidepressants.
So she has a history of gradual worsening of depression over the course of the last 3 months. In addition, she seems to have chronic low mood. So this is one of those scenarios where we have to consider dysthymia, worse in the evening. So there is the diurnal pattern. Frequent bouts of crying when alone, moderate anxiety, sometimes even associated with panic attacks, and then something that might suggest a higher level of arousal because she has mid-nocturnal early morning awakening. During the day, she reports fatigue.
She also reports a 15-pound weight gain in the last 3 months associated with increased appetite and binging, but no purging. She has a markedly reduced libido, complains of poor concentration, and is not interested in daily activities. She denies active suicidal ideation, but says, I feel like I might be better off dead. Denies any obvious precipitant to you for her symptoms, and her PHQ-9 is a 20.
So she's severely depressed.
She is.
Her past history is remarkable that she had bulimia during her college years, but it is currently in remission. Had approximately 5 episodes of depression in the past. Initial coincided with childbirth at age 25. And presentation of that initial episode is very similar to the current one. She had irregular menses with decreased duration and flow in the past year. So maybe some hormonal issues to consider.
So, or perimenopause at least.
Or perimenopause, that is right. So multiple SSRIs and SNRIs have been tried. Nothing worked better than 50%. Escitalopram patient remembers as being maybe a little bit more effective than the rest. As soon as her depressive episodes started improving, she would discontinue medication. In between the episode, she did suffer from moderate anxiety and had otherwise no remarkable medical history.
She's married, but she basically says she and her husband live separate lives and stay together for convenience. They are living together, though. They have 2 grown children not living in the home, and she's been working at the same job as an executive secretary for over 2 decades. She reports moderate social drinking, 3 to 4 drinks per week, and denies any illicit drug use.
So after comprehensive discussion of treatment options, Mrs. Robinson expressed no interest in psychotherapy. She wants medications, and based on the fact that in the past she responded to escitalopram, treatment with 10 milligrams of escitalopram was initiated.
So she comes in 2 weeks later. You get your patients in quickly for follow-up, and she says she feels better and appears noticeably improved to you. She had some mild nausea in the first week, but that's resolved, and her PHQ-9 is down from 20 to 12. At 4-week follow-up, more symptomatic improvement, endorsing better life functioning, and PHQ-9 has dropped further to 8. But at 6 weeks, she comes in and she looks significantly more depressed and tearful. She doesn't want to continue to take escitalopram, and her PHQ-9 scores back up to 16.
That's pretty odd, don't you think? Something may have happened there?
Something happened.
Let's see if we can shed light on this mystery. So we need your help here. At this point, the most appropriate course of action would be to, number 1, agree to discontinue the escitalopram immediately and observe the patient for worsening. 2, convince the patient to try a different antidepressant that might work better. 3, emphatically explore why the patient, empathically explore why the patient wants to stop an antidepressant that appears to have been working for about a month. 4, review in detail how the patient is taking her antidepressant. And 5, 3, and 4. So majority of you, overwhelming majority, think that 3 and 4 would be, exploration of the reasons to stop and reviewing how antidepressant is taken, that's the right path. I don't think
so. We're going to do that. Mm-hmm. Is she taking her escitalopram? She's kind of evasive in her response and finally admits that she stopped taking the medication 2 weeks ago. So right after the last visit, when she was more improved, she stopped taking it. Is she having side effects? And she basically has trouble talking about it, but says, it takes away my ability to enjoy myself. And that's why I've always stopped taking antidepressants. I've always just been too embarrassed to mention this.
But if I remember, she was also not very close with her husband.
No, she wasn't. So she's sort of suggesting that this is masturbation. So we asked about her partnered relationship, but we didn't really ask about self-stimulation.
So at this point, the most appropriate course of action would be to, number 1, emphasize to the patient that clinical benefits from antidepressants more than compensate for loss of sexual function. 2, discontinue escitalopram and switch patient to an antidepressant with fewer sexual side effects. 3, explore more deeply with the patient the nature of sexual dysfunction she's experiencing, and discuss potential treatment alternatives. And 4, all of the above. Okay, so majority of you think that number 3, exploring the nature of sexual dysfunction and discussing potential alternatives, would be the way to go. Yep.
I think sometimes we're concerned this is going to take up more time than we have, but the truth really is that she will continue to have recurrent episodes and will have all these other problems if we don't address it. This is the time to look at that issue. She says basically the SSRI made her unable to have an orgasm, and you basically bring up, well, we talked about your relationship with your husband at the first meeting, and then she starts to cry, says she's having an extramarital affair with a younger man. He's unwilling to leave his wife. This seemed to have something to do with the onset of her depressive episode 3 months ago. She's worried he's going to abandon her. Now that she's gained weight, she's even more fearful of that, and she feels guilty that she's not meeting his needs. The truth really is that her needs are not being met if she's not able now to come to orgasm. But he may, in fact, feel somewhat inadequate if that's now the case.
So at this point, what is the most appropriate course of action? Number 1, tell the patient that if she discontinues her extramarital affair, everything is going to get better, right? 2, is explore with her potential connections between her extramarital affair and her depressive relapse. 3, do not address her psychosocial situation. There's no time here. And recommend she restarts escitalopram and add bupropion on top of it. And 4, discuss with the patient what is known about options for minimizing sexual side effects during pharmacologic treatment of depression. And 5, 2, and 4. So exploring the connections and discussing what is known about minimizing sexual side effects. So what do you say? Glad to see that option 1 is not getting a whole lot of positive response.
Right. So, sorry. Oops. Sorry. Can I go back? Upon discussion of alternative treatments, Mrs. Robinson says, I still don't want to have therapy. I don't want to talk about this with a stranger, essentially. But she did express some interest in trying a drug with a multimodal mechanism of action, and doesn't want to gain weight, doesn't want the sexual side effects. She's now clear about that because you've been talking about it. And she says, I'd rather stay depressed than have those things happen. But based on her past history of SSRI intolerance due to GI side effects, a decision was made to initiate treatment with the lowest dose of an MMA.
2 weeks later, Mrs. Robinson called saying that she has experienced only mild nausea, which has resolved, but only minimal improvement in her depressive symptoms. She was asked to increase the dose to mid-range. 4 weeks later, less crying, denied even passive thoughts of suicide, still has little initiative and interest in life, and sleep is minimally improved. Her PHQ-9 is now 12. On the good side, I've not noticed any sexual side effects and my appetite is under control. Can I try a higher dose? Dose was increased and she was asked to schedule an appointment in 3 to 4 weeks.
So this is a pretty positive thing for her to be requesting dose increases, I think. When you see her then, her affect is much brighter. She's wearing makeup. She looks a lot more animated. Her PHQ-9 is 6. She feels like this is the right treatment for her. It's easier to start and complete tasks. Her concentration at work is noticeably better. She feels like her old self. She's confident. She's enjoying things. And she denies any really significant side effects except some nocturnal sweating, which may be related to the perimenopause and not the drug at all, and feels she can live with that. And when asked about the changes in her personal life, she just smiled and said it's okay and didn't have any interest in talking about that further.